Hello, Ming. How are you?
I'm good this morning. For you?
Thank you. Yes, thank you. Thank you for taking some time to join us today. We are with Dr. Ming Lim. And Ming, welcome to Rare Awareness Radio. And I'm going to go and say that you are a leading expert in pediatric opsoclonus-myoclonus-ataxia syndrome, which is a lot to
Right.
say. But
It's a muscle. Yes.
you've really contributed significantly to the diagnosis and management of OMAS. I have a lot of questions for you, as you might imagine. But before we jump in, would you just mind giving us a quick little bio sketch, Ming? Tell us about yourself, where you're located. I think that would be really helpful for the audience.
Yes, sure. So I'm Ming Lim. I'm a pediatric neurologist. I work in London. That's in London, United Kingdom. I work in a large, children's hospital here called the Evelina,
Mm,
Children's Hospital,
yep.
and it's one of the few children's hospital with a comprehensive service in neuroinflammation in
Yeah.
children. And this is where, I come across children with a whole host of rare inflammatory conditions, including OMAS, which,
Mm,
as you pointed out earlier, it's a mouthful, but
mhm.
it represents each of the symptoms that the children have.
Right. So speaking of symptoms, is there ever, and I'm sure the answer is no, but is there a typical presentation of OMAS in children, Ming? Talk to us a little bit about that.
Sure.
Mm,
So usually, like all syndromic descriptions of condition,
mm,
once you have all the parts of the symptoms, it becomes very obvious. The penny drops. But
mm.
like in all conditions, it has to start somewhere.
Right,
And the problem is that when it starts somewhere like opsoclonus, which is the abnormal eye movements, or
right.
myoclonus, which is the abnormal sort of movements, there are lots of differentials, meaning that you have to think of other conditions, that might cause that. And that usually leads to the delay in sort of diagnosis. And
Mm,
whilst we often make diagnosis based on what is the most common,
right,
because OMAS is so uncommon, it
right.
often gets left out right until the end
Mm.
before the diagnosis is made.
Has a lot of what you've observed, when I talk to parents and I talk to caregivers, they talk about the diagnostic odyssey, right? They talk about the challenges in diagnosing OMAS, and I know that you and others are doing work on how early diagnosis can be improved. How are you feeling that work is progressing, Ming?
Yeah, no, I think it's progressing well, particularly with the publication of the consensus
Yeah.
document, looking at how we can improve early diagnosis. And fundamentally, I think with human nature, unless you think about it, you're not going to diagnose it. And
Right.
if we can get it into people's mindset that this is one of
Mm.
the few things you need to think about, particularly if you start to have protracted symptoms over a longer period of time and the convergence of many other symptoms as well, this should be a differential.
Interesting. You mentioned the international consensus report. It's a great segue. So, in just for the folks that don't know, in 2022, you published an international consensus
Yep.
report. You and several others, and really a treatment sort of modality or algorithm was proposed through that consensus report. Ming, can you just elaborate a little bit on the recommended approaches for managing OMAS that came out of the international
Yeah.
consensus
No,
report?
no, sure. So just to take a step back,
Sure.
the group, that com contributed to this consensus had been meeting, almost, 2 decades ago in 2004, and every
Wow.
2 years, sort of we would meet,
Mm,
and it was after many, many sort of meetings that it was decided, actually, folks, we've got to sit down and get this on paper.
mm,
Otherwise, it will just be us, talking about it. And once it's on paper, many others, sort of can read it.
yeah.
And up till that point, there were two differences, and it remains two sort of strategies in treating OMAS. One is the more upfront strategy, as we call it, meaning that you would treat with all treatments available
Just
at the
everything.
same time. Yeah,
Okay.
front loaded, they call it.
Okay.
So with steroids, with IVIG, with
Mhm.
the stronger sort of maintenance treatment. Whereas in Europe, where the the studies have shown, or not studies, but because we were recruiting, to a clinical trial, the
Right.
clinical trial was proposing a stepwise, sort of approach, meaning that you start someone with less effective treatment, and if they were symptomatic, you would escalate it,
Yeah,
slower.
step it up. I see.
Step
Okay.
it up as such.
Yeah,
And
interesting.
what we did in the consensus was just to highlight the two different approaches and provided strategies for researchers to move from one aspect of the paradigm to another. So meaning, let's say if you were to take a stepwise sort of approach, by contrast, when we were escalating it over periods of months, we would be escalating it a lot faster after this consensus. So it is a bit of a hybrid between the two.
Yeah, and I'm assuming proving effective.
Proving effective, indeed.
Yeah, that's amazing. When we have interviewed several folks on this conversation about OMS, OMAS, and there, sometimes is the presence of neuroblastoma, right?
Mm.
And could you just talk a little bit, Ming, about how the presence of neuroblastoma influences the treatment, influences the prognosis of children with OMAS?
Yeah, no, it's a very perplexing, condition that, in at least 50% of children, you find this neuroblastoma. And all it sort of illustrates is that, the body's attempt to get rid of the neuroblastoma, we think at least, mounts an immune response. And that immune response cross-reacts with, the sort of brain antigens, and it attacks, the brain, as well. And despite there being two groups of patients, whereby there is one with a neuroblastoma and the other without a neuroblastoma, we can't seem to find that many differences between both the groups, at least immunologically or from the clinical presentation. So OMAS behaves exactly like OMS with or without neuroblastoma. There might be some subtle differences, like some studies have shown that if you were younger, you were more likely to have the neuroblastoma, and if you were obviously a little bit older, you're more likely to have the infection sort of triggered neuroblastoma. So probably the same sort of mechanisms that triggers the immune response. In the younger group, it's probably the tumor, but not invariably. And in the older group, it's more likely to be other infections, but you can also have tumors, triggering, that. And the treatment of the neuroblastoma from the brain immunity perspective is no different to if you have the tumor or not. But of course, if you have the tumor, then treating the tumor itself has to be the key, factor in management. And that
kind of the prioritized approach is to eradicate the tumor first, right?
Absolutely. Yeah. And sometimes some of the treatments targeting the tumors can have similar effects for treating brain immunity, because what essentially has happened is that over the years, treating brain immunity, we've just borrowed treatments from cancer because they can work in fairly similar ways. And in those situations whereby some of the treatments share characteristics of the brain anti-inflammation treatment, then we don't have to double up treatment. Whereas if it doesn't, then you still have to treat. You have to treat with anti-cancer treatments as well as anti-immune treatments of the brain.
It's so fascinating how you said how the brain sort of almost gets mixed up, right, in its response, and how the body is trying to fight off the immunocompromised situation from the tumor. It's amazing. It's amazing.
Yeah. And I think the other interesting aspect of this is that, and nobody knows why this might be the case, but there are interesting theories, is that if you do have a neuroblastoma, or if you have a brain syndrome, then your neuroblastoma is often always milder compared to children without the brain, response. Is that because the immune response is more active?
Right.
As such. And I think that's one of the key areas that lots of scientists are thinking about and looking into as such.
Another great segue, kind of thinking about what the scientific community is researching, Ming. I like to tease Mike Michaelis, the founder of OMS Life Foundation. I kind of call him the godfather of this podcast. It was his idea. And as you know, we're not just focused on OMAS, we're focused on all kinds of rare and underrepresented diseases. Mike was a big proponent of that. But I also know Mike is a big proponent of registries. And I know there is the International Pediatric Onset OMAS Registry. Can you talk about the registry, its impact on advancing research?
Yeah. As you know, with conditions, being rare, if you go to any sort of researcher, let's say in the UK
Mm.
or in America, and you ask them, how many patients have you got, and we're going to say, oh, I have 25, and then another will say 30, 50, depending on whom you ask. But ultimately, each of these are collected in a slightly sort of different way.
Mm.
The outcomes are different. And the way to really pull all this together is a registry,
Yeah,
essentially.
of course.
And that's what sort of Mike and his group had the foresight many years ago, that the only way we're going to make a difference is to get all patients together. So
Yeah.
that's one benefit. And of course, the other benefit of having a registry is that you actually know where the patients are.
Yeah.
And in case there are studies coming up, collaborative with other institutions, or I hope in one day, newer treatments coming in, then we know where the patients are, so we don't have to go looking for them, or actually, waiting for them to declare themselves,
Sure.
in so to speak.
I worked on a device registry back in the late 90s, early 2000s for anti-arrhythmic or arrhythmic devices,
Hmm.
implantable and rhythmic devices. We were building a national registry of everyone who had an implantable device. A lot of challenges, right, associated with building a registry.
Yeah.
Ming, so I've got some firsthand experience. You do as well. Talk to me a little bit about some of those challenges associated
Yeah.
with that.
Yeah, so I think the key challenge here is, confidentiality of
Mhm.
data,
Yeah.
because obviously, these are rare conditions, and the data that you collect are really, although really important, may, and because of the rarity of condition, despite it being anonymized, you can inevitably unmask the anonymity, just because it's so rare as
Mm.
such. So, for example, I say there were three, patients in the UK that presents with very, very young, i.e., OMS under 1.
Right.
Although I've de-anonymized it, they're going to know that there's only three patients. So that's one, sort of key, challenge as well. And of course, the other key challenge with all sort of registry is, making sure that the data is used for only,
Right.
the correct and intended purpose. So
Of
patient
course.
and parent consent, is integrally sort of, important. And I think the third big, challenge of all registries is making sure it's up to date, and making sure that every year, the data is updated and renewed, because it's only as good as the data that you sort of put in. And
Yeah.
I tell you, and you will only have to ask Mike, that it is an enormous task,
Effort.
even to
Yeah.
get it to this stage. But what
Right.
I'm saying is that in 5 years' time, to keep it as useful, it's going to take lots and lots of man hours type thing. Yeah.
Absolutely. And that to me really kind of speaks to this multi, disciplinary collaboration that takes place both from the clinical care aspect. And I'd ask you to speak a little bit about who you work with in a typical case, Ming.
Mm,
But then to your point, there's so much more collaboration that goes on outside the four walls of just your institution, right? So can
right.
you share some of the insights that you've seen on how the multidisciplinary collaboration is just table stakes, I guess, for caring with for children with OMS?
Yeah, sure. So for the patient themselves,
Mm.
a typical MDT, i.e., multidisciplinary team, would
Yep.
consist of a primary neurologist. Depending on where your sort of healthcare provider is in the UK, we have a primary pediatrician looking after that child, because they may
Hmm.
come from quite a long way, and
Sure.
they would coordinate all the needs for that children. But from in our institution itself, we will sometimes need an immunologist if some of the treatment that we're giving is, not what a neurologist would give.
Sure.
You would, of course, need an oncologist, if there was a tumor. And then you would need all the therapists, the
Yeah.
occupational therapist, the physiotherapist, the speech and language therapist, the
Sure.
psychologist. And, many of these children may subsequently have, although recover well from the neurological aspect of the disease, may not recover as well from the cognitive
Yeah.
aspects, and they will need longer term sort of follow up. And I think that would be sort of a typical sort of patient
Mm.
pathway. But of course, the patient may not go through a typical pathway, in that, after a year, they may sort of, relapse, they may have,
Right.
challenges. We may
Right.
be unsure whether our treatment strategy is correct. And this is where, the collaborative effort is sort of really important.
Really
And
important. Yeah.
in most countries, there will be a national network, but,
Mhm.
because we have access to all these sort of researchers in OMAS, we also have an international sort of, access.
Makes
And
sense.
I think that's important. And then, of course, what the two groups, which you probably, you know of Mike's, sort of group, which is OMS Life, and you know about the dancing eye syndrome,
Right.
support, trust. What they do is actually link parents that do ask about their children with respective sort of experts. So that's how the sort of network also helps, so that we can, direct them to their nearest,
Right.
expert. So
Yeah.
as
Well, and
such.
thank you for talking a little bit about the long-term cognitive and developmental outcomes. I think, with children diagnosed with OMAS, you mentioned sort of the need for PT, OT, all of this extended therapy as you kind of try to address these longer term outcomes that are associated, right? Um,
Yes.
Immunotherapy is another area, Ming, that I wanted to ask you
Mm,
about, and sort of the role immunotherapy plays, in
mm.
managing OMAS and sort of the considerations for its use. Can you talk to us a little bit
Yeah,
about that
sure.
approach?
Yeah, I think if we take a step back, for any neuroinflammatory condition, we
Hmm.
know that early institution is important. And if you remain symptomatic, you need to escalate. And that's what we now call optimal treatment, whereas before we used to call it aggressive, treatment
Yeah.
as such. And for OMAS, the story is the same.
Mm.
The longer you have symptoms, the poorer the outcome. The more relapses you have, the poorer, the outcome.
Right.
And therefore, we think it's really important, even if you take the stepwise, sort of approach, or slow escalation approach, or
Hmm.
not front loaded, you need to escalate if the patients are symptomatic.
Sure.
And of course, the key challenge in OMAS at the moment is that we don't really have a biomarker for the disease. So there's no
Yeah.
antibody that I can measure that will say
Right.
I've got
Just look at.
the
Yep.
condition. And therefore, one that can delay sort of diagnosis, and that may make it more difficult for us to monitor sort of, the disease as well, other than
Hmm.
just having the symptoms
Hmm.
itself. So yeah, so it's important twofold, because we know it is very similar to other inflammation, and why should it not be? The communal theme has to be that. And if,
Right.
but particularly for OMAS, we know that it affects the very young child. So the
Right.
average age for a child is just under 2. So 18 months is the mean or median age.
So
And
it's so
the
young.
young inflamed brain does not, do as well as the older sort of inflamed brain. And that's probably why we may even argue that you might need to treat it a little bit more aggressively or optimally,
Mm.
compared, to other, children.
Is that because when you're so young, your brain is evolving and growing so
Yeah.
much, so quickly, so rapidly? Yeah. Yeah.
Exactly. It's just
Yeah.
it's just making networks, right?
Mm.
And from 2 to 5, we know that there's an explosion sort of
Sure.
connections being made. And if you imagine that, an inflammation stunts it, sets it back some way, and then
Mm.
it prevents you from developing, during that, next few years. So you're losing out on two folds. One, losing all the connections that you've made and not making new connections.
Sure.
That's why
Sure.
it's very, very important we get on top of it as, quickly as
Quickly as
possible.
possible. Yeah.
Yeah.
And kind of segueing from, getting on top of something to advocacy. Um, I'm here in the US, you're in the UK. We definitely benefit from the level of academic medicine that's available to us in both of our countries, right? But there are families, there are clinicians that don't necessarily have that, available to them. Is there advice that you potentially offer clinicians or families to sort of try to ensure optimal care and support for children that affected by OMAS, especially if they're not maybe in the benefit of being here in the UK or in the
Yeah.
US?
And I think, I mean, that's where, going back, to that consensus, document again, it also paints what should be a investigative pathway, diagnostic pathway, and monitoring, pathway for children, i.e. what's the minimum they should
Yeah.
have. And that will set the standards. And of course, one has to be mindful that, setting the standards in a higher income country may be entirely different for a lower sort of middle income country, but at least that gives you, a ballpark figure of what to sort of aim for. So parents now on reading, those consensus themselves, because that's made available,
Right.
so there's open access, so everybody can read
Yeah, I was
it.
able to find it. Yep. Yep.
Yeah, albeit medical jargon
Right.
heavy, but their respective physicians will then certainly be able to read that. And what actually has happened is that because we've mapped and named all the experts within that field, the physicians have been able to look them up to wherever their country is, and I'm told contact them, sort of directly.
That's
As
outstanding.
well.
Yeah, that's outstanding. Yeah, that's amazing. It saves them the challenge of having to try and do it
Yeah.
on their own, right?
Yeah. Well, saves me having to triage it and sending them on to the others.
That's even better. Yeah,
Yeah.
even better. Ming, what do you most sort of need? And this is probably a very loaded question, Ming, but I ask you, like, when you think about sort of the key areas of research and the potential advancements that can be made to understand and better treat OMAS, what is it that you need?
Yeah. So without a doubt, the registry is what we need in terms of, pooling all, the information, together. And from the registry already, not just the registry from OMS Live, you may have heard about PUMAS, which is a study launched from Boston's children. So that's led by my colleague, Dr. Mark Gorman, who is collecting all children presenting with OMAS across 5 continents. And the difference between this and the registry is that this collects real-time data, including all the scientific data, the clinical presentation, the MRI, and where samples sort of are kept. And they have reached a first phase in terms of a data lock, meaning that they've collected enough patients already to start to look at treatment outcomes of patients. So in some of these I can't remember the exact numbers, but we're close to 150 on the data lock. It means that in these 150 patients, we can now go back and look at how they were treated initially, how much had a lag of treatment, and what their outcome is. The reason being that contemporary data is always different from historical data, because as you know, medicine doesn't change in just one dimension. It changes in your overall health provision, your overall social health provision, and better medicines. So if you compare it historically with a group, you always don't get the fairest comparison. Whereas now, we do, and by including patients from different continents as well, you can sort of pick out differences across the 5 different sort of regions. So I think that's definitely one. The second is, like all things, science really does need to help us unravel. So the simplest question is, why do some patients respond to treatment and why some don't respond to treatment? What constitutes sort of unresponsivity? Is it because patients have chronic or more likely to have chronic inflammation? And we are starting to learn some of those that they are genetically predetermined. So for example, if you look at MS, which is a condition that multiple sclerosis is, children also do get multiple sclerosis, and they're slightly more frequent than OMAS. And because there are lots of adults with multiple sclerosis as well, we can the immunobiology of that is better worked out alongside the immunobiology of chronic, sort of inflammation. So learning from those and applying it to rare, conditions, I think is what we really need to, and how we can move, forward. And that's why, the collaboration usually comprise of people that look after not just exclusively OMAS, but a whole host of other inflammatory, conditions as well. And then ultimately, I do think that a third component is actually access to some of these treatments. We again really assume that, and I was totally shocked when we met our colleagues from other nations that some of the treatments that we take for granted is not accessible there. And if we were to take MS as the one of the examples, we know that in the UK for children, we can probably access 12 to 13 immune treatments. But in some parts of the world, despite the WHO putting it on the what we call essential medicines list, and that's 2 or 3 drugs only,
Right.
they still can't access it.
Wow.
So that's the sort of
Challenge. Yeah.
challenge that we
Yeah.
sometimes have.
Yeah.
So colleagues in, I am told in Brazil, who is a country with quite a big OMAS, population,
Interesting.
will struggle to get rituximab, which
Mm.
is what we assume to be the front line everybody
Frontline
should
treatment.
have
Yeah.
if need
Yeah.
be.
Interesting.
So I think the three would be that, and I think there are some healthcare provision sort of differences. We know that in the UK it's a National Health Service, so once
Right.
decided at a national level that is the standard, you would get it already. Whereas I think in countries where it's more sort of insurance driven, there is that added layer of complexity. Although
Sure.
I
Yeah.
gather that with an established treatment pathway, you could almost argue a reason for that with most, insurance,
Yeah.
companies.
And get
These
through
days.
that
So it shouldn't be a problem. Yeah.
get through that dreaded prior authorization and
Prior,
authorization.
that's the word I was looking for. I
Yeah.
couldn't remember that
Yeah,
word.
that's okay. Absolutely. Ming, before we let you get back to the important work that you're doing and on with the rest of your day, when you think about, what it's continuing to motivate you, what you are most optimistic for, I know you spend a lot of time with patients and families, and I'm sure that's a big motivator for you. The work that's being done internationally sounds like is an amazing sense of motivation for you. But what are you most optimistic for, Ming, as you continue your work?
Yeah, well, I'm most optimistic that we are now speaking, the same language.
Right.
Even up till 2-3 years ago, we were, speaking, very different terminologies. So, for example, with at least we think harmonize what the diagnostic criteria should be for OMS,
Mm,
how you would define disease remission, not as easy as you think, because you
right.
can ask 2 or 3 different people that, not suggesting that what has been, proposed in the criteria is correct, but it's a stepping stone. It is, a harmonizing sort
Mhm.
of language, so that ultimately we collect the same sort of data so that we can cross compare it,
Right.
across. So, and I think what's also really rewarding for me is that we're borrowing the strategy that we use for OMAS to translate to other, conditions, as
Mm,
well. And as physicians get more and more used to doing, similar sort of, collaborative, strategies, I think there is a strength in benefiting from other conditions as such. So for example, it may take me a long time to establish a
sure.
collaboration with somebody who has got 2 or 3 cases of OMS, but if I was collaborating with them already on another condition, it would
Right.
make the rapport sort of a lot easier. So I think
That
this
much. Yeah.
international collaboration has really grown in that sort of strength. And if we were to take an example, at a last meeting, probably about 2 or 3 meetings ago. So we meet as a steering group for this, international
This
group.
collaboration. Yeah.
Yeah, someone talked about, there is a specific way of looking at eye movements using, AI
Oh,
or
sure.
using.
Yeah.
And in fact, in this group, and this was a colleague in Canada, have been using it to correlate with cognitive outcome. So
Mm,
immediately, Mike could get onto his cohort and say, hey, why don't we just do it on some of our sort of, US, patients? And I believe there's a, collaboration there now. So,
that's
every
great.
meeting that we have, you know, something comes out of it. In
Take another
fact,
step forward potentially. Yeah.
it's just exciting, every day, every other week, every other month, and hopefully, every 2 years we have this landmark meeting that we get together to exchange, all these sort of progress. So you might have heard that, every 2 years we meet in
Yes.
Abingdon, in
Yes.
Oxford, the historical meetings. This is our 11th meeting this year. So
Outstanding.
we've been there for 22 years, actually slightly more because there was a big lag for
COVID.
COVID.
Yeah,
Yeah.
sure. Yep.
And yeah, and that's why I'm optimistic, and the numbers are just growing. It is so
Yeah.
more and more people are getting interested and excited about the condition.
I love that. And thank you again for doing that work. We've been speaking with Dr. Ming Lim. Ming, thank you for your time. Thank you for joining us on Rare Awareness Radio. And please continue to do the amazing work that you're doing. We are so appreciative of that. And we look forward to speaking with you again soon.
Thank you very much.